unfortunately, there are many patients who have more widespread metastatic disease. We need to think about drugs. I'm going to turn to James. You've been a leader in this area. Let's start about mTOR. Start with mTOR inhibition. I think you showed early on that treatment with everolimus is effective in pancreatic neuroendocrine tumors. Recent study shows it's probably also active in other types of neuroendocrine tumors.
Yeah, so that's really a great segue to discuss this. As everyone knows, everolimus was approved for pancreatic neuroendocrine tumor in 2011 based on a RADIANT-3 study. But still, there was a lot of unmet need in other neuroendocrine tumors of other sites. Among them, essentially, there was very little data for any sort of treatment, including SMAS analogs in lung neuroendocrine tumors, and there was very little data for therapy for any sort of large bowel, like colorectal neuroendocrine tumors. So RADIANT-4 was really designed to address that. It's a randomized phase 3 study. It was 2-to-1 randomization for everolimus versus placebo. And the stratified by primary site. Stratum A was mostly mid-gut tumors and unknown primary, and then the stratum B was the more badly behaved tumors. What we showed in the study, which we just recently published, is that there was a 2.8-fold improvement in median progression-free survival, so more than a 50% reduction in risk of disease progression. And at the time of the final progression-free survival analysis, a first interim overall survival analysis was also conducted, showing a trend toward benefit. So definitely we still have a lot more to learn from the study with more maturing of the data following up for overall survival and how did the patient do in terms of quality of life. And hopefully these data will be coming soon.
In addition to mTOR inhibition, you've also been involved in another strategy. These tumors are known to be highly vascular. Sunitinib is approved for pancreatic neuroendocrine tumors. What about the role of anti-angiogenic therapy in carcinoid tumors?
Yeah, that's a really great question. I think at this point we really don't have a definitive answer to that part yet. There's certainly great scientific rationale to look at anti-angiogenic therapy in neuroendocrine tumors because these tumors are very vascular, and there are a lot of data in literature showing that VEGF and so forth are prognostic in terms of outcome in these patients. And so sunitinib was FDA approved also in 2011 for pancreatic neuroendocrine tumors. But the role of sunitinib in non-pancreatic primary is undefined at this time point. There are other drugs that are being studied. One was bevacizumab, and that was looked at in a phase 3 study of which is the SWOG 0518, where we compared octreotide plus bevacizumab to octreotide plus interferon. What we saw is that there was a higher response rate in the bevacizumab arm, but no difference in progression-free survival. There was a little bit of improvement too also in time to treatment failure, probably more reflecting the adverse event profile than anything else necessarily. So unfortunately, I think the question for bevacizumab remains not clear. So if you thought interferon was active and had a role, and the two arms look certainly nearly identical in PFS, then Bev may have a role. But if interferon is just giving toxicity and have no benefit, then Bev probably cannot be interpreted to be of benefit either. There's one other VEGF inhibitor that's been looked at, which is pazopanib. I think you and I, we did a phase 2 together across Dana-Farber and MD Anderson that's shown promising activity, especially in the pancreatic NET group, but also potentially PFS benefit in the carcinoid group. And there's a study ongoing in the cooperative groups with pazopanib in non-pancreatic NET. And that randomized phase 2, as I understand, has completed accrual. And I think there's thought whether or not we should expand it into more of a phase 3 study to answer the study the role of VEGF, anti-VEGF therapy in a more definitive way.